Patient breakfast. Met some of you guys on interviews. There we go. Good afternoon. I'm ever so slightly sarcastic, so just get used to it. It's not going to change. I graduated from the PA program in Fort Lauderdale a few years ago, and I've been practicing basically at Fort Myers since I finished school. I came right out of school and started in neurosurgery. I spent the first 12 and a half years of my career in neurosurgery. Went on for about 2 years in general and vascular surgery, and then went back to neurosurgery before I came to teaching full-time. I taught as an adjunct here when the program started in 2005, and then came on in December as full-time faculty. And I've done ER work kind of on and off. Basically, when you guys eventually take your boards, you'll realize that there are about 6 questions on neurosurgery on the entire board exam, and they're the same 6 questions every time. So needless to say, every single time I was prepping to take the recertification boards, I basically worked in the ER because it was the easiest way to study. So, you know, nothing like sticking yourself with a needle, becoming your own patient. That was me. Any questions? All right, so let's get going. So today we're going to be talking about interviewing as a clinical skill, and then we're going to move right on into chief complaint and history of present illness. Those are the 2 lecture topics that we'll be covering today. I'm hoping to have the past medical history lecture that'll be for Friday, any revisions she might make for it, posted to you by tomorrow afternoon. I always try to get things up and running the afternoon ahead of the lecture, okay? Sometimes I tend to change things the morning of, but I always make the revisions and put it back up on Blackboard. So I like this. I have this in my office. So what's wrong with me? Well, you're an arrogant jerk, an idiot, the worst stinking son of a, and I guess you flunked out of bedside manner. And I love the little tagline down here, and it says, you're a goner and adios muchachos, okay? So we have all met those healthcare providers that are just horrible with regard to bedside manner. And the person that you may necessarily want cutting on you doesn't necessarily have that kind of bedside manner that makes you feel all warm and fuzzy. And our job as physician assistants, regardless of what type of field we go into, is to be that bridge between the physician and the patient, okay? Maybe the physician doesn't have as much time. We have the opportunity to really have a better rapport with our patients. And certainly I've had experience in my career where I've had physicians which are a little abrupt. And so certainly it's nice to be the one to be able to come in and kind of smooth everything over and make sure everybody's nice and calm and comfortable, especially as they're rolling off to brain surgery. So, 2 of the things that I wanted to talk to you about today were 2 of the core values that Dr. Terry Morrow Nelson discussed in your orientation breakfast on that Thursday morning. And one of them is our integrity. And this is something that even the president of the university, when I was at my doctoral graduation last September, really talked about having to maintain our integrity as providers. And so really who you are every day and how you present yourself to the world is critical to how your patients perceive you. So if we aren't the same person when we get up every day and we kind of go out and be someone that is fake, your patients will perceive that. And not only your patients, but other healthcare providers. So it's always important, and you need to start forming that now, that you have that inherent integrity inside you that, yes, things go poorly, and things go bad in our lives, but at the end of the day, we're the same person. We're very genuine. And the other thing is diversity. As my mother always says, you don't have to live with anybody, okay? You only have to tolerate them for 72 hours. She means that when she talks about company. So you don't have to love everybody that you are in class with. You don't have to love all of your professors. All of your patients you are not going to get along with. Do you need to be able to tolerate their differences? Yes. Doesn't mean you have to embrace it, but you have to respect where they're coming from. And if you can do that and remain objective, it will beseech you in your career moving forward. So the objectives, we're going to talk about various forms of communication. We're going to talk about, don't fall asleep on me. Understand the approach to medical interview. I have, in fact, thrown Twizzlers at people's heads in the past. Very bad throw, by the way. And understand the goal of the medical interview. So we talk about various terms. We talk about objectivity. So it is striving to remove one's own beliefs, prejudices, and preconceived notions from our observations. So we always don't want to take what we think is going on into the situation. We want to be able to hear that patient out. We talk about precision. We want to be able to, yes, anecdotally use what we have experienced in our own practice to talk to our patients, but primarily we want to know what is in the research, what's in the literature that we can tell our patients that are solid facts that we can give them to help them make their decision moving forward. We talk about sensitivity, so that's the ability to pick up real cases, versus specificity, which is the ability to rule out diseases in a normal patient. Okay, so all the time when we talk about laboratory values, I'm sure you guys have had this in all your prereq courses, sensitivity and specificity, the ability to rule things in as well as to rule things out. And then we talk about reliability and reproducibility, and that's the ability to get the same result over and over and over again. We don't really get that a whole lot when we talk about gleaning a history, because patients tend to change things a little bit. As you move through your physical diagnosis class with Professor Patch, soon to be Dr. Patch this weekend, you will start to glean and understand that reliability. That basically, if you do the exam or if you do the exam, you should get the same results. So my first boss, coming out of school, Dr. Bhatia, always talked about the practice of medicine. And he always used to tell patients who were coming in and who were a little bit cynical, isn't it nice that we are in the practice of medicine? And that's where, you guys are taking anatomy with Dr. King, and anatomy is pretty solidified, right? I mean, there's some stuff about the brain we don't know, but we've named all the arteries and we've named all the nerves. But truly, the practice of medicine and how patients respond to things is an evolving process. So you always want to make sure that you're telling your patients we're still practicing. Okay, we're still learning things. If you are very good at gleaning an appropriate history and physical, though, you'll get about 70% of your information from what the patient tells you. A lot of it is in the story that they tell. So allow them to tell it to you without you having your own prejudices on what they should be telling. When we talk about a strong clinician-patient relationship, we know that we get better results. Patients, even if they don't do great, they are happier with their outcome. Versus if we had that poor communication, that poor breakdown between patients and clinicians, we know that not only are outcomes worse, but malpractice is higher. Okay? Knock on wood, never been sued. Been deposed for a manslaughter case. But he apparently didn't mean to kill her. But I've never been sued. Okay? So you always want to make sure that you have that open rapport with your patients. So much so that when we talk about competency domains between the Accreditation Council and graduate medical education, they've taken both professionalism as well as that ability to glean an appropriate history and physical as part of their core competencies. Yeah, they've got everything else. You've got to be able to do a good history and physical. You've got to be able to evaluate diagnostic studies and come to the right differential diagnosis. But they want you to be professional. They want you to be able to talk to a patient. So, interviewing, we talk about active listening. So this is where active listening is where volunteers come into place. I'm just randomly picking pictures. So do we have, where's Melanie? Where's Miss Cohen? Miss Cohen, what's your favorite movie? Sound of Music. Okay. How about, do we have Bob? Bob, what's your favorite novel? Quickly. What's your favorite TV show? Polish language. We're moving on. Where's Steven? Steven, what's your favorite movie?
Forrest Gump.
Forrest Gump. Okay. And let's see. How about Ashley? Where's Ashley? Okay, Ashley, what's your favorite TV show?
Bates Motel.
Okay. So you want to, we're active listening. So we're removing preconceived notions and we're letting the patients tell us what they want to share. Bates. So when we also talk about preconceived notions, we talk about what that patient comes into us and how they perceive us, especially with that white coat on, okay? So a lot of us going back, harkening back in history, they perceive us as healers. They perceive us as the one who can take away and alleviate all of their ailments. And for some patients, that's pretty frightening because it's a matter of the fact that they just don't understand how that's even possible. That's not because necessarily they're uneducated. They just might be educated in a different area. Okay, Okay, they might be very simple and not necessarily be dumb. Okay, so some patients actually fear us because they don't understand how a surgery can make them feel better. They don't understand how the medication can actually fix their hypertension or fix their diabetes. And some actually idolize us. Okay, we had one patient who used to bring, I don't know why, like guns that didn't work anymore, fortunately, but old guns to one of my bosses because he knew that he collected antique guns. And every time he found one, he brought him one. And we had operated on him 10 years before. So it's like we weren't even seeing the person anymore, but he was so thankful and so grateful. That was the way he showed his expression, okay? They believe that we're all-knowing, unfortunately. They don't really understand that evolution, that it is still the practice of medicine. And they think that we should be able to have all the answers, oftentimes quite disappointed when we don't, quite disappointed when there is no cure for what's ailing them. And then again, we do have the classic white coat syndrome. Okay, so those patients who, they don't want to come see the physician, they don't want to come see the PA because they're nervous every time they do. They're assured that every single time they come to see us, we're going to find something wrong. Okay, and they kind of can't help it because you turn on the TV and there's Cancer Centers of America, and there's MD Anderson, and there's the Susan B. Komen Foundation, and there's this walk for that cancer and that walk for this cancer. All great organizations, all doing great stuff, okay? But it's everywhere, okay? When I taught some of the breast lectures to the other class, basically breast cancer now is 1 in 8, right? Okay? So in the 1970s, it was 1 in 30. Is it really more common, or are we just finding it more often? And there's this hypersensitivity of it, right? You kind of can't get away from it. And so a lot of patients don't necessarily want to come to us because they are concerned. The minute that we start saying, or they start saying, well, I've got this mass in my breast, I'm worried, we're already jumping and diagnosing them with cancer. When in fact, you could take that 32-year-old female, and she comes in and she's scared to death that she has cancer. And you talk to her and you evaluate her, and you find out, well, it's worse around the midpoint of the month, it's worse when she drinks a lot of caffeine, and all of a sudden, yes, she's getting a mammogram, but you could just console her and say, you know, it's probably just fibrocystic breast disease and it's probably benign. And in 2 seconds, alleviate all those fears and concerns. So you cannot allow patients to diagnose themselves and become so worried. You have to alleviate those concerns. You have to get them back to their symptomatology. Don't let them sit there and, WebMD or Wikipedia everything. So we talk about sensitivity and specificity. Again, take the focus away from the diagnosis. Remember that all your patients are going to come in with like a laundry list. I talked to my neighbor and my mom and the woman who lives down the street, and they all have the same symptoms, so I must have this. And they're coming into you reading a laundry list that they've gotten off the web of what they should have, rather than telling you what's actually happening to them. Okay? So get them back to their symptomatology, get them back to why they came to see you that day. Listen to their story that's being told, allow the patient to basically paint that picture for you. Okay? Yeah, you're going to have to navigate it, and we'll talk about that today when we talk about history of present illness. But basically allow them to open up and give that information to you. Basically what you're doing is you're trying to focus down your physical exam. You're trying to create a diagnostic plan. Not everybody gets a CAT scan. Not everybody gets lab studies. Okay, yeah, a lot of people do, but you can't just carpet bomb and order every single study that's out there. Okay, what do we always call it? Oh yeah, carpet consult. Patient gets admitted to the hospital. We're going to consult neurosurgery, orthopedic surgery. We're going to consult the intensivist. We're going to consult pulmonary. Okay, not everybody needs to be on board. Consult the people that are necessary. Get the studies that are necessary. And if you get an accurate history and physical, you actually know what studies are going to actually get you to your diagnosis. We talk about reliability, and again, reliability really goes more so with physical diagnosis than it does with history. Patients, unfortunately, and not for any fault of their own, but if you're the third person coming in to interview that patient, they might be changing their story. And it's not malicious. They don't mean to do it. But you might be asking a question a little bit differently than someone else did. And by doing that, well, maybe the pain's not really epigastric, maybe it's a little bit more so to the right. Did the patient really change their story? No, maybe it's just how it was asked to them, okay? But when we talk about reliability, it's the same study being done over and over again and getting the same results. And the best example that I could find is truly the National Institute of Health Stroke Score. And it basically is a study that's done in 3 minutes. It's a clinical exam done in 3 minutes. That if I do it, or the neurologist on the TV, or somebody in Seattle does it, we all get the same score. And this is the study that's done that drives the use of tissue plasma antigen, which is TPA for stroke. But basically, you want that inter-examiner reliability. And you try to get to that with your history taking. So you try to get to the point where, at least with you always ask the same things all the time. And that way, when your patients come in, you kind of have your own little mantra. You have your own little stepwise fashion that you go through. Especially when you go then to presenting to either a colleague you're passing off, like you're working in the ICU, hey, I've got this patient in the bed, and this 24-year-old white female came in with pneumonia, X, Y, and Z. They know they always pass the information from one person to the next in the same fashion. Same fashion, you can go out to your attending, okay? Hey, I've got so-and-so coming in, this is what's going on. They know that you always walk through the same mantra. All right, so when we talk about active listening is communication technique that's used in counseling, training, and conflict resolution, but it basically requires you to truly listen to what is being said. So we've got Stephen over there. What was Stephen's favorite movie?
Forrest Gump.
Okay, and what was our favorite TV show? Yeah, that's not going away. Sorry about that. And what was our other favorite movie in the back? Sound of Music. Very good. So active listening means that you're engaged and you're listening to what your patient's saying to you. It does not mean that as you're on your phone over here and your patient's talking, you go, so what I hear you saying is that you've got some abdominal pain. Because if that was me sitting in that chair, I'd be like, yeah, I just told you I had abdominal pain. Where's your doctor? Where's your attending? Where's your colleague? Okay? You don't want to sit there and just repeat back to the patient everything that they have just said to you. Patient's not a moron. Neither are you. Okay? Make sure that you're actively engaged with them. If you need to clarify something, that's how you say it back to them. So you got some abdominal pain. Can you be a little bit more specific about where it is? You're opening up that open-ended question. You're allowing to get more information. Kind of allowing them to tell their story with more clarity. So it helps develop that therapeutic relationship. Basically, the patient knows that you're listening. They know that you're not, thinking about, well, I got to pick up my kids for soccer tonight, and I've got to get to that ballet class, and this weekend we're going out of town, and I really got to pack. Okay, your patients don't care. Your patients want you there for whatever time you're sitting there. And it promotes ownership of the issues. So if you have a patient and they say, well, I keep having this cough, and you know because you've seen Bob for a year, well, Bob, are you still smoking? I mean, I know we haven't been talking about that today, but I've known that from your past history. Yeah, I'm still smoking. Do you think that's maybe a problem? I mean, that's where you can actually allow them to see that what they're doing is causing detriment to their own health, okay? You can refer back because you've always been listening to that patient as they've come in to talk to you in the past. And it lends itself to educating your patients, okay? Basically, if you've been listening to them the entire time, you can help talk them through changes they need to make in their lifestyle moving forward. Now, when we talk about you eventually going out, everybody always feels like they're the fifth wheel. You don't want to feel like that you're the fourth or fifth patient or student coming in to evaluate another patient who's sitting in a hospital bed who the last thing they really want to do is once again talk about their medical history. But it's all in the way you approach it. If you approach a patient and you say, would you mind if I took 5 minutes of your time to really practice getting a good history from you? Then you're allowing that patient to kind of have a part in your education. It's not necessarily that you're taking away time from them. Seriously, if they're in the hospital, what else are they going to be doing? And if they don't want to participate, all you can say is, if this is a bad time, I can come back later. If you would prefer not to repeat your history, that's fine. okay? I'll just read your chart. But it would give the patient the opportunity to participate in your history, or excuse me, participate in your education. And truly, the majority of patients are more than happy to help you along the way. Sometimes people feel like an interloper, especially when you walk into a room and there's a ton of family in the room or a ton of family and friends. Again, just ask if there's a better time that you can come back to be able to glean that history. Remember that the simple act of sitting down is very important. So there was a clinical study done out of the University of Kansas. I actually couldn't believe it was that recent, in 2010. But basically 95% of patients, the post-visit comments were positive when the clinician sat, versus only 61% when they stood. The interesting thing about that study is that they appreciated it as being 40% more time, when in fact, when you looked at the actual time spent, they spent less time when they sat than when they stood, but it was perceived as being 40% longer. You come in? Question?
Go ahead.
Oh, okay.
I'll ask when you're finished.
Okay. So all you have to do is come in, pull up a chair, sit down. That simple act of doing that is what allows the patient to feel more engaged. Number one, it typically puts you at eye level with them, which is huge, because then you're just talking to them. It's not this, I'm up here and you're down there in the bed. Okay, I've sat on the bed with my patients. I had one former surgeon who I knew who would simply take a knee at the end of the bed. Some patients like that, some patients did. It's not a football game. It's a hospital room, okay? So sit down with your patients, okay? Don't belittle what they're going through. But truly, if you do that, you simply take the time to just sit. Number one, it places you in the appropriate mood and setting to actually get information from them. And number two, it allows them to just be more open and honest with you. So when we get a history, we talk about a chief complaint. Yes?
Right, so my question was about that. Like, not particularly bedside settings, but like when you go into an office setting and they're sitting up on the table. I'm a little shorter, so if I sit down, I'm going to be looking pretty far up, especially for a taller person. Is that?
That's actually even better.
It's better to be.
It's better to be below them, eye level wise, than to be above them. So even if, like, without my heels, I'm not that tall either. So basically, I would sit, and half the time I'd be sitting on a rolling stool in my office, and I'd be lower than them. And that was always better than standing. Yeah. So we talk about a history of present illness, past medical, past surgical history. In that lecture, you'll get allergies and medications as well. Social history, or what they call now psychosocial history, and a review of systems. Versus the interview process, which is piecing together that information. It's actually the ability to elicit accurate information. Not what the patient wants to tell you, or what they think you want to hear, but what is actually going on with them. And actually being able to have interpersonal skills. The majority of my patients, so when I worked in the ER, one of the nurses had a little bell, on the side of the thing. And I was horrible because I would work downtown at Lee, so it was a lot of inner city patients, and it was kind of hard because how do you discharge someone to home when home is homeless, but they would come in and they'd see me, and of course I had this bad habit of calling everybody honey or babe. So they would hit the little bell every time I call them, I'd be like, hey, hon, and they'd hit the bell. Because they were like, you can't call these people who live on the streets honey and babe all the time. They're going to come back every single time you're working. Sure enough, they would come back every single time. So I treated a lot of repeat customers. We'll talk about getting ready. Be prepared. Always have a pen with you, okay? If you're an Earl and you tend to put your hair up in a bun and put your pen in your bun, remember that your pen is in your hair. Someone to do that, okay? Make sure that you have some place to write on. Make sure that you walk in and you're not asking to borrow a pen from the patient. Make sure that you look appropriate. Okay, set goals for the interview. Make sure that you self-reflect. Know what your values are. Know what your prejudices are going into an interview. I had one lady and I walked in and she was there with her partner. And I walked in and I was, I don't know, probably in my 20s at the time. And the first thing she said out of her mouth was, we're gay. And I said, I'm straight. And she was like, oh. And I'm like, What's the big deal? And she's like, nothing, just wanted you to know. And I'm like, okay. I'm like, moving forward, you need back surgery, you know? But I couldn't believe, I guess just me walking in, she just assumed I would have a problem with it. So you just kind of immediately set that tone, like, we're good, you know, let's keep going, all right? So just make sure that you know your own assumptions, you know your own biases. Basically, that woman didn't know me, of course. She assumed that I would have such an issue with her and her partner. You walk in, you have no problem. We had a great relationship, okay? Review the chart. Make sure that you don't walk in there not knowing anything. Walk in knowing a name, okay? Again, you want to glean a complete history, so you don't necessarily want to walk in there and be like, oh, so you're the one who's got colon cancer. Oh, okay, so we're going to do this, you know, talk to your patient. Hi, Mrs. Smith. It's nice to meet you. Is this your husband? Is this your son? Okay? Know that the allergies are taken care of. Know that the weight and the height is all there and the medications are all there. Make sure, but don't go in there with a preconceived notion, having completely read everybody else's history and physical to where you might as well not even walk in the room. If you're going to walk in the room, make sure you're there to get additional information. Be professional, both in behavior and appearance. We are not baristas working at Starbucks, although sometimes that, on a bad day, that looks like a good option, okay? But we are PAs, okay? So you always have to look like you're put together, even if you don't feel like you're put together. The only time that it's appropriate to look like you've rolled out of bed is when you actually have rolled out of bed, okay? And it's 2 o'clock in the morning. But at 2 o'clock in the morning, guess what? The trauma patient still should look worse than you do, okay? So, you know, pull up your bootstraps, put your scrubs on, you know, lace up your sneakers, you know, run a brush through your hair, might I have to say, okay? Always look like you're unhurried, okay? We all have 50 million things going on. Everybody has 50 million things going on. I love it when people come up to me and say, I'm busy. And I'm not, okay? So put stuff down, sit down. That's another reason why just sitting helps. Sit down, calm down, listen to what the person's telling you. Don't look like you're running around with your chicken with the head cut off, okay? Focus. Adjust to your environment. Know that if you're in a hospital setting, yeah, you're going to have less time. You're going to have more things to do. You've got a laundry list. If I used to always just keep my running list of patients, little tally of what I had to do, you check it off and you get through it as the day goes on. Whereas when you're in an office setting, yeah, you tend to still be busy. You know, you're talking 15 minutes with the patient. Understand what you have to identify within that 15 minutes. Understand that if you are running behind, because with my when I worked in general and vascular surgery, we would run an hour behind. Me and my boss on a Wednesday, we would see 60 to 70 patients. We'd start at 7 in the morning. We'd finish at 7 at night. We'd finish dictating at 8:30 at night. We'd work through lunch. That was the only way we got caught up, though. It was fantastic. Because we'd work through lunch, and by 1 o'clock, I was actually seeing my 1 o'clock patient. It was awesome. Then I'd still get an hour behind. But if your patients know, well, they're always running late, but every single time I see them, she sits down with me, or he sits down with me, and I talk to them, and they act like they have nobody else to see. They spend all the time with me that I need. And sometimes that's only 5 minutes, and on other patients that is 15 minutes, okay? But make sure that you appropriately change how much time you spend with patients, what kind of juggle, what you have to do, what information you have to glean from them. If you're in a busy ER or emergency department, you know, you've got your older patient who can't hear and they're saying, speak up, and you feel like you're screaming. So what you're telling me is you've got drainage, okay? Make sure you pull the curtain. Try to speak as softly as you can, but understand that if a patient can't hear you, they can't appropriately answer your question either. So yes, there is HIPAA, okay, there is all the Privacy Act, but you still have to be able to glean information from your patients. Take notes, make sure that you're gathering information. Your patients may not be giving it to you in a concrete fashion. They might be coming at you from all different directions, especially if you have a spouse in the room. That's fantastic, because you're looking at your patient and the wife is sitting back there and they're like, so have you been having any abdominal pain? He's like, no. And the wife is like, and you're like, oh, okay, so what's really going on? So make sure that the patients might be coming at you from multiple directions when you're actually gleaning a history and physical, but when you give that information onto a colleague, when you give it onto an attending, it has to be presented in a nice, formatted fashion, okay? This is a 64-year-old female, presents today with abdominal pain. It started 3 weeks ago. She's tried multiple medications, which haven't improved her symptomatology. You can't be like, well, she had that, but then she went for this study, and then the pain kind of got worse, but then she's tried some Rolaids, then she went to the ER. You can't be all over the map. The patients are allowed to be all over the map. We have to be pretty precise and pretty thorough. So we always want to greet our patient. We always want to be respectful and polite, okay? This is like what your mom taught you when you were going to kindergarten, okay? Be respectful, be polite. Try to avoid first names unless you get to know the patients over and over again. Certainly if you don't know how to pronounce their last name, everybody butchers my last name, by the way, it's Knudsen, okay? But I've gotten Knudsen, Knudsen. It's fantastic for like solicitors. I just know that they don't mean me. But if you don't know how to pronounce someone's first name or their last name, just ask them. And I've gone in and I've asked them the first time. I've still butchered it the second and third time. And you just ask them, I know I'm pronouncing it wrong. Tell me again, okay? They don't mind being asked. They mind if you're not polite. As long as you're polite and courteous about it, they'll tell you 5 different times. Make sure that you introduce yourself and you reintroduce yourself. That more so goes when you're in a hospital ER setting. Remember, that person just has to meet, you just have to meet that person and all your other patients. But you're walking around with a cheat sheet all day, right? You got your list. That patient has to meet you, plus your attending, plus the speech therapist, the occupational therapist, the home health agency. They've got to meet all their other attendings. They've got to meet the radiation technician who's come to pick them up for their ultrasound. They've got to meet the dietitian, their nurse, their CNA, okay? They've got all these different people, and they've got to keep everybody straight. You just have to keep them straight. So reintroduce yourself every single time you walk in there, especially when you have additional family members. Hey, my name is Katie, you know. Are you daughter? How are you guys related? Okay, always just kind of open-end that question, because you never know what you're going to get, especially in this area. A couple times. So you must be his daughter. No, I'm his wife. Oh, sorry about that.
How do you reintroduce yourself without being rude, like you're saying that they wouldn't remember who you were?
Well, you don't, it's not like every 5 minutes, but if you're going in, and so the next day you're going back and you say, hey, my name's Katie, I met you yesterday. Oh yeah, okay, I'm with so-and-so. Because, and especially in a lot of your larger practices, you may not just have one attending. Like in my surgical practice, I have 9. You know, so they may have seen Kowalski one day, but Boggs the next, and Mon the day after that. I'm with Kowalski. Who's Kowalski with? Oh, he's with Boggs. Oh, okay. And it helps to put that together in their mind. You don't have to really go, I'm the PA, you know, but just briefly reintroduce yourself. Yeah. Okay? Always greet the visitors. Always know that it's okay to ask the visitors to leave. There don't need to be 15 people in the room. Okay? Visitors are typically 2 at a time. So I have absolutely no problem with kicking people out of the room. You do it nicely, okay? But you just say, listen, I need you guys to leave. I need to do a clinical exam. Really, unless it's the spouse, kids don't need to see that. You know, maybe a boyfriend doesn't, maybe the patient doesn't want anybody in the room. So you ask the patient, do you mind if so-and-so stays? If they refuse to leave. And if the patient just kind of looks at you, you kind of proceed, you do a clinical exam, but maybe you don't necessarily make the patient naked. Okay? But always make sure kids, little kids especially, you ask them to leave the room. Friends, out of the room. A note about cell phones. If you do not want your patient to be on them, do not be on them yourself, okay? Understand that, you know, nowadays we don't have necessarily pagers as much. Everybody just texts or calls to the cell phone. But you don't need to look at it every single time it goes off. If you're expecting an important call from your physician or from a colleague, that's one thing. You excuse yourself, or even when you walk in, you tell the patient, hey, listen, I met you yesterday. Just as a forewarning, my attending might be calling, and I don't mean to be rude, but if he calls, I gotta take it. Let's talk about what's going on with you today, okay? If you know that the call is imminent. Otherwise, really, one can't wait 5 minutes, okay? The majority of your patients will get through telling you what's going on with them in 2. So you can take the time to ignore the phone call. Yes?
So then, do you recommend keeping it like on silent or vibrating versus on
I always kept mine on vibrate. Yeah. I never let mine ring just because everybody has 50 million rings, and the last thing you need to hear is a Taylor Swift song going off while you're trying to interview a patient, you know, because everybody has their own ringtone, you know. So I would keep it either on vibrate or on silent, okay? And then you check it when you leave the room. But so this is a funny story. One of my really good friends in town, she's an orthospine PA. She's been a PA for like 14 years. So if you think I'm sarcastic, just wait if you ever meet her. So she walked into a patient's room on the weekend, 2 separate male patients, and she's, you know, I don't know, she's cute and young, and you know, she always wears lots of eye makeup. She loves her eye makeup. So anyways, she walks into the patient's rooms, 2 separate men are on the phone, and all I said was, "Oh, honey, I should probably go in a minute because the nurse just walked in the room," which is, of course, one of our favorite comments. And she's like, "Oh, you need your nurse? I'll go get her." She left the room. She didn't come back. She finished all of her other rounds, and then she came back. And they were like, "Oh, you're the PA." She's like, "Yeah, I'm the PA." Okay. If you want I hated that when I would walk into the patient's room and they'd be talking on the phone. They'd be like, "Oh, they give you this. This is my favorite." Just a minute. Yeah, I'll give you just a minute. I'll give you about 10. I'll be back later. Okay. So just don't. You know, your patients should get off the phone. You shouldn't be on your phone. Don't walk into a room and be talking on the phone as you're walking into a patient's room. Don't pick up a phone call when you're in a patient's room. Make sure that you're always just keeping that on your side, on silent, or it's at your desk. Nothing really needs to be that important. Trust me, if someone dies, they'll find you. Remember that this is not your interpretation of the history, it is their symptomatology. Recognize the patient's personal space, okay? Just like Dirty Dancing. This is my dance space. This is your dance space, okay? Don't come too close to the patient. Some patients really have that claustrophobic feel if you get too close to them. Sit at eye level with your patients or below, okay, to get to that question, especially when we're talking about kids. If you ever like to go into pediatrics, remember that kids get very intimidated by healthcare professionals. So if we can even get down, I used to always just squat down and sit right next to them. Okay, they love that because then they almost like feel like they can pat you on the head. Look at your patient, not at your tablet, not at your computer. I know we're all on EMR these days, but don't be like, "So here you've got this abdominal pain. How long that's been going on?" Okay, don't stand with your back to the patients. A lot of the computers now in the hospitals, unfortunately, the way they've situated them, they really didn't ergonomically look at it very well, but they have a lot of our backs to our patients. Take your history and physical, and then turn around and enter it into the computer, okay? Or walk to the nurse's station, or walk to the dictating station, and enter it into the computer. A lot of the times when you start really getting into your routine of obtaining a history and physical, the majority of the stuff you can just remember in your head, okay? Yeah, you write down notes, but you're not having to sit there and verbatim take down everything the patient is saying. You're remembering everything. You're having a dialogue with your patient. Ask open-ended questions. So don't be like, "So your pain's in your right upper quadrant?" "No, your pain's in, so where is your pain in your abdomen?" Okay, just allow them to tell you your story. And again, this helps to lead the patients, and if you listen to your patients without interrupting them, the majority of them get through what they need to tell you in 2 minutes. So if we sit with our patients, I think in that study it said something like if you sit for a minute and 14 seconds, they perceive it as being 40% longer. So if you sat for a minute and 14 seconds, if you only sat for another 46 seconds, the patient would get through their story. And then you could actually do your clinical exam and be out of the room in probably under 5. So it doesn't take a whole lot of time, just don't interrupt them. And don't be interrupted, okay? We talk about non-verbal communication. So we want to make sure that we look at how we're standing, how our posture is. Again, that gets back to making sure that you don't look like you're hurried all the time, like you don't have 500 other things to do. Everybody has 500 other things to do. Just don't have that look on your face. Don't have that look on your face that somebody says, "Well, I've had this drainage." Drainage. Where's that coming from? Okay? Don't do that either, okay? Have a poker face, okay? Make sure that, you don't always look like, there's one person I need to talk to about this, who I work with. he looks like everybody has cancer all the time. Okay? He does. He's always like, and I'm like, you're either constipated, which is a whole other problem, or everyone has a bad diagnosis. Okay? So you have to make sure that you really have a poker face. You could sell anything, that nothing phases. All right? This goes way back, but my anatomy teacher at high school, and I went to Catholic high school, okay? She basically said, you can ask me anything, and as long as you ask me with a straight face, I'll give you a straight answer. People asked her anything. She gave a straight answer, okay? Catholic high school. It's pretty good. So get a good poker face, start early, get that now. Otherwise I'll be yelling at you when we get into simulation. And this goes for patients. So look at how they're sitting, look at their posture. Remember how they always teach you in communication, don't sit with your arms crossed and your legs crossed and like you're, like you could care, okay? Uncross your legs, uncross your arms, lean a little bit forward, look engaged, look like you actually like your job, that you want to be there that day rather than in Hawaii on vacation. Who wouldn't want to be in Hawaii on vacation? But look engaged with your patient. Look like what they're telling you is important, because it is. All right. Show respect, be genuine. This is easy. If your patients start to get to know who you are, they'll start to understand, for my patients, my sarcasm, okay? They'll start to appreciate that. They understand that you're always going to be honest with them. Even if it's bad, that you're always going to tell them. And if it's not bad, you're going to tell them that too. So make sure that you establish that early on with patients. And make sure that you have empathy. You have to demonstrate that you appreciate what the patient's going through without saying, oh, I know how this is. You don't know how it is, okay? And they're not your mother. That person in the bed is not your mother. It is not your spouse. It is not your child. So you get to empathize with the patient and be kind to them, but you don't get to grieve for them. You don't get to kind of go through things with them. I had one boss, and he would almost cry with patients until I pulled his butt out of the room. I'm like, get over here. We're not doing this, okay? If you lose patients, yes, you'll lose patients in your career. They are your loss as a patient. They are not your loss as a family member. So make sure you keep a very distinct line that you are there to help in whatever way you can, and when you can't help, you are there to call in potential like spiritual services and all that kind of fun stuff that can take it from there, okay? Draw a very distinct line between clinician and friend, and clinician and counselor, okay? All right, I finished early. I always finish early. Oh, not that. Okay, so we'll take 10 minutes, okay? We'll come back maybe at 5 minutes till, and we'll start into chief complaint and history.